Welcome, everyone. Thank you for joining us. This is a webinar, part of our RUNX1 Research Program Medical Education webinar series. And today our webinar is entitled Recognizing Pediatric Hereditary Hematologic Malignancies. I'm Katrine Erickson. I'm the Executive Director of the RUNX1 Research Program, and I will be your host today. So again, welcome. Next slide, please. So before we jump into the program, I'd also like to just briefly share with you a little bit about RRP and then some available resources you might find valuable. I recognize some of you may already be familiar with RRP, so apologies. But to those of you who are not, we are a nonprofit organization dedicated to supporting patients with RUNX1 familial platelet disorder. We were started by a RUNX1 family in December of 2016. And our mission has stayed the same since then, and that is to improve the quality of life and, most importantly, prevent blood cancers in RUNX1 FPD. As many of you may know, RUNX1 FPD patients have a close to 50% lifetime risk of developing a hematologic malignancy, and it's most commonly AML or MDS. So our strategy toward achieving our mission, it not only includes hosting medical education webinars and supporting our patient community through education, through research collaboration and community building, but really the majority of our funds goes towards research grant making. And thankfully, we're able to do this with a number of amazing nonprofit partners. So together with groups like Alex's Lemonade Stand Foundation and the American Cancer Society, we've been able to commit now over 16 million in research dollars towards understanding this disease and towards discovering cancer prevention treatments. So you can imagine that this webinar series is very much a part of this mission, and it's important to us that we, as a community, recognize that these germline predispositions to hematologic malignancies have been underappreciated, and that we really do need to improve the diagnosis of these conditions. So our shared goal today here is to make sure that families are diagnosed as soon as possible, and if that can happen, then we might get closer to our goal of blood cancer prevention, not only in RUNX1 FPD, but hopefully in many other similar conditions. So now the ugly QR codes on the screen. The first QR code on the left is a resource that we created with a nurse practitioner, actually from Boston Children's Hospital. She had spent most of her career there. She's actually now at the University of Washington. And she's performed over hundreds, if not thousands, of bone marrow biopsies. And the reason we created this resource is it's a two-sided one-pager on how to improve the experience of bone marrow biopsies. And the reason we did this was because it is a chief complaint of many different patients in our community. Because of the number of bone marrow biopsies they have routinely, many of them have unfortunately suffered discomfort and significant pain. So this is sort of just tips and ideas of how to hopefully minimize any pain or discomfort from a very experienced woman. The second QR code on the right is a link to the RUNX1 and Inherited Hematologic Malignancies Consortium. This is an international group of non-malignant and hem-onc physicians, both adult and pediatric. The group also includes pathologists, it includes geneticists, as well as a large group of genetic counselors. And they're all working together towards, improving and driving progress in these cancer predisposition syndromes in heme. And so currently at the moment, they're working on the RUNX1 FPD clinical consensus guidelines. And so if you know someone who sees these patients, please consider contributing. We're in the first round of the survey, and we want to be able to have as many people participate in this survey so that it truly is a consensus guideline. I think that's it for me. So thank you for your attention. Next slide, we'll start with our program. So today I'm honored to have Dr. Serine Avagyan, who is our main speaker. Dr. Avagyan has been a truly active member within the RRP research community, and we're grateful for her passion and commitment to the research, but also for her passion as a pediatric hemonc physician specializing in the care of children with myeloid cancers. And she is currently now an associate professor in the Department of Pediatrics, Division of Blood and Marrow Transplantation at the Eli and Edith Broad Center for Regenerative Medicine and Stem Cell Research at the University of California, San Francisco. Um, at, Following Dr. Avagyan's presentation, we'll have a 15 to 20-minute Q&A discussion, and it will not only include Dr. Avagyan, but also Dr. Jess Pollard from Dana-Farber Boston Children's Hospital, as well as genetic counselor Sara Torres-Esquius from Vall d'Hebron University Hospital in Barcelona, and I will introduce them more formally before the Q&A session. Just so you know, as a participant, as an attendee, please feel free to throw in your questions at any point during the presentation. We'll have a Q&A log. You can submit anonymously. Other attendees won't see. Only I will be able to see the questions, and I'll be able to direct them to our panelists at the end. So please, any question is a great question. So without that, or without further delay, rather, I am pleased to welcome Dr. Avagyan. Serene, over to you.
Thank you. Thank you, Katrine, and thank you for the quick promotion there. I'm still an assistant professor, but I'll take the associate calling anytime. No, I'm joking. Thank you very much for this introduction and an exciting opportunity to share with you some of our some of the ways that we think about the workup of patients with hematologic malignancies and how to recognize hereditary aspects to this. I'm just going to hide the video panel so I have all of the. All right, here we go. So. I guess the main objectives to go over some of these very quickly at the beginning is going to be discussions, case-based encounters to discuss clues and some tools that we could use towards identifying these hereditary hematologic malignancies, and really no order of importance. This will include specifically a discussion in somatic landscape of cytogenetic and genetic alterations as being one of the keys, some features of the disease, particularly related to the pathology, the preceding cytopenias, and perhaps the recurrence patterns of the disease that could be used towards this, family history considerations, and we'll mention briefly some non-hematologic manifestations, some of these syndromes that will be also important. I do want to mention that all of these, and perhaps even more topics, are themselves like an hour presentation each, or pages of review. So by no means this is going to be comprehensive to a point that will be sufficient to cover the whole entire topic. So as a way of introduction, I do want to stress the importance of recognizing that there's increased incidence and recognition even that germline predisposition underlies early onset blood disorders, which includes children up to the age of 18, but also young adults that typically, considered up to age of 40 years. Typically, the red flags that we think about with patients having an underlying condition would be, for example, the presence of first and second degree relative with hematologic or solid tumor cancers. The history of personal malignancy in the past, whether that might be hematologic or non-hematologic, might clue us into that. Certainly, the presence of immunodeficiency or preceding cytopenias often make us think whether there was a preceding process, for example, a systemic process that was affecting hematopoiesis in general, that could be contributing. More and more often, as somatic panels are part of the workup of presentations in blood cancers and blood malignancies, gene variants that might be close to heterozygous clone size are sometimes cluing us in that these conditions might be part of the process. And certainly historically, this physical stigmata and more recognition of non-hematological features of this conditions or specific conditions can clue us in as well. But I guess the key points that are really important to remember is that the germline predisposition can really underlie blood disorders at any age. So you might be taking care of a teenager and know about a family history in a 67-year-old person that should absolutely contribute to your thinking. So it doesn't have to be specifically in early onset nature. And really, the important part is that the lack of any of these above that I just mentioned really does not rule out germline predisposition. And the constant suspicion is really what probably leads very often to this discovery. And as we go along in the presentation, I will point to these key features in these purple squares or rectangles in the sidebar, just to kind of maybe prompt a little bit more attention to those points. So a few words about the incidence of these conditions, and these numbers by no means are ones that are set in stone, and this is quite dynamic as a field. But based on literature that is as up to date as I could possibly come up with for today's topic, is these are really the typical percentages that have been reported, and BALL being the lead type of hematologic malignancies in children may encompass about up to 5% disease that is related to germline condition. TLL and AML, as shown here, a little bit less common, might have 3 to 5%, and AML a little bit more. So myeloid cancers have a little bit more incidence of germline predisposition, and that can be up to 15%. Now, the story becomes a little bit more profound and maybe critical to recognize in conditions like myelodysplastic syndrome, where the incidence of germline conditions can be up to a third. So, percentages like 30% have been reported in literature. And most critically, in this very small subset of BALL called low hypodiploid ALL, which we'll come back to, the incidence of germline TP3 mutations may be up to 50%. So the disease itself can gauge that pretest probability of this, the disease having an underlying germline condition. So the why is quite an important aspect to this discussion, and I think as a physician, as providers that are taking care of the children, for me personally, one of the most important things is the proper diagnosis, and I think this has been recognized now also in the classification of myeloid and lymphoid neoplasms, where there's a dedicated section to hematologic malignancies with germline predisposition. In addition to the proper diagnosis, this obviously leads and is tightly connected to optimal treatment and conditioning, whether that might be chemotherapy or conditioning regimens for stem cell transplant, with a main goal to reduce non-relapse complications and toxicity. For example, in conditions like Li-Fraumeni syndrome or telomere biology diseases, that becomes quite important. Another aspect to why it is important to diagnose these disorders is that the donor selection for a stem cell transplantation, which very often is the curative means for this patient's diseases, should avoid getting the stem cells from a donor that is affected by the same condition, right? In order not to transplant the same disorder back to the recipient patient. And indeed, this leads to very important considerations of family member testing and counseling, and specifically even for the patient themselves, genetic counseling and family planning for the future. And lastly, as we learn more and more about the non-hematopoietic features of some of these conditions, the anticipation of these complications is important and sometimes really contribute heavily to the morbidity and sometimes, unfortunately, the mortality of these patients, even after the fixing of the hematopoietic system by a stem cell transplant. So with that, we'll just dive into the cases right away, so we can have a platform and specific examples to discuss. So case one is that of an 8-year-old girl with a 3-month history of intermittent cones. So nothing specific. She is not herself, as the parents report, which can be, quite informative and not very helpful sometimes, but this is an important aspect to this story. There's a family friend who had not seen her for a few months and maybe mentions that she looks a little pale to her. And the family very promptly sees their pediatrician who obtains basic labs. So previously, the child has been healthy with normal growth and development. There is a history of breast cancer in her mom. So mother was diagnosed with triple negative breast cancer in her early 40s. And at that time, she had a testing that was reported to her as being negative, genetic testing for inherited cancer predisposition genes. Her father and her 2 siblings are healthy. So the physical exam is notable for a mild pallor. There's no organomegaly, and otherwise the exam is unrevealing. So the laboratory values that you receive as a hematologist or an oncologist is the following. So she has some leukopenia with a white count of 2,200. She's anemic with hemoglobin of 9.8. The mean corpuscular volume, the MCV, is quite high. It's at 103.5, and her platelets are low at 85,000. She has mild neutropenia at 1120 and some lymphopenia as well as low monocyte count, but there are no abnormal cells or blasts on her peripheral smear. So even from this very quick vignette, there's 2 very important aspects that I'm sort of filing and thinking about as I'm thinking about her case. One of them is this positive family history of a non-hematologic cancer, so this early onset breast cancer in the mother. And the second one is this very obviously profound and obvious multi-lineage cytopenia with ANC, low platelets in hemoglobin, but with very also notable macrocytosis, so large red cells, which is a little bit unusual for aplastic anemia, for example, that is mediated by immune destruction of stem cells. So the referral to the hematologist oncologist is prompt. That leads to a bone marrow evaluation within a week. And so the pathology in this case shows hypocellular marrow with up to 20% cellularity in some patchy areas. There's no increase in CD34 blasts, but there is an abnormal population of c-KIT or CD117 positive myeloid progenitors that corresponds to the flow cytometric analysis. And there's a few dysplastic megakaryocytes that is noted by the pathologist. She has a karyotype or cytogenetics, which is pretty standard in this kind of evaluations, that shows that 9 out of the 15 colonies are missing chromosome 7, that is consistent with loss of chromosome 7. And the FISH panel that is done in this particular sample corroborates that with a positive monosomy 7 finding in 40% of the cells. There's a somatic leukemia panel that is done, which identifies 4 variants. 2 of these variants are in GATA2, the other 2 in WT1. One GATA2 variant is at a variant allele frequency or a clone size of almost 44%, and it's reported as to be pathogenic. And of note, all the variants that I'll show you throughout the talk, except for when it's not the case, they all are going to be pathogenic or likely pathogenic. I won't list them every time, but just know that that's how it was categorized in the reports. So again, just looking at the key points of these information that we have a hypoplastic, hypocellular marrow, but with presence of dysplasia, which is again something that should clue us in that there's an abnormal process happening in the marrow. The finding of monosomy 7 is going to be quite critical to think about. And of course, this GATA2 variant in a somatic panel that has about heterozygous variant size, close to 50%, plus minus 15%, is what clues us in what might be going on here. So this case was diagnosed as monosomy 7 myelodysplastic syndrome, of MDS, because of the hypocellular marrow, the monosomy 7, and the dysplasia. And indeed, the concern with this, with the GATA2 variant 1, was that it might be a germline contributing to the pathogenesis. And she had a germline panel testing initially, but at the same time, concurrently a buccal swab, which confirmed that this particular variant was actually germline. And this this case was then the final diagnosis would be GATA2 deficiency associated MDS with monosomy 7. Now, because the treatment for this is very promptly to plan for a stem cell transplantation, which is the definitive curative therapy for this, our family members who are HLA type HLA matched siblings and the parents who are haploidentical were actually tested for this variant in order to, as I mentioned, to identify the appropriate donor. And in this testing, it was found out that the mother who had the triple negative breast cancer was the affected parent in this case and carried this variant in her buccal swab. And the interesting twist in this story was that her blood sampling actually at the time showed that the variant allele frequency of this germline GATA2 variant was 4%, which is suggestive that she had experienced what's called a somatic genetic rescue and reduced that mutant clone size in her blood over the 40 plus years. So one quick key note here is that germline testing ideally should be done on cultured skin fibroblasts, which is the non-hematopoietic tissue that is very often probably considered as a gold standard in the testings like this. But really, that's when time allows. And a lot of times when these children have to proceed with a stem cell transplantation and the donor evaluation is an important part of that process, alternative methods of more quicker turnaround tests is used, such as buccal swab testing, skin biopsies more recently, and often hair follicles. And in some areas and institutions in Europe, nails are used as well. And then the second piece, as I already mentioned, that the cascade testing for family members really is prioritized depending on the clinical care and the donor selection process. This is not to say that the remaining family members should be forgotten, of course, but sometimes the time-sensitive nature of this is quite important, and prioritization and focusing the family's attention to the members that perhaps are critical in the care of the patient is important. So a few words about monosomy 7 and 7q in pediatric blood disorders, as this is one of the most common genetic alterations in non-lymphoid and non-lymphoid blood malignancies. This can be a loss of chromosome 7 completely, or maybe a partial loss of the long arm of chromosome 7 by derivative 1,7 or a deletion of 7q. I think personally, to me and perhaps many of my colleagues, this on its own actually has a high value positive predictive finding for germline hematologic malignancy predisposition conditions. And the reason is that, almost every bone marrow failure condition that has a leukemia risk, a lifetime leukemia risk, has been associated with monosomy 7. Now, the top two conditions to think about is GATA2 deficiency, which is the case in our first case. And the second one is a SAMD9 or 9L syndromes, which both have a pretty high incidence of monosomy 7 disease. But again, as I said, most, if not all marrow failure and leukemia predisposition conditions have been described with this pathophysiology, maybe rarer in Diamond-Blackfan anemia and perhaps even rarer in pediatrics associated with telomere biology diseases, but certainly has been described. And 2 words on GATA2 deficiency pertaining to this case. It is inherited through an autosomal dominant pattern through heterozygous variants or deletions, and the variants have been described in all parts of the gene, most commonly in the zinc finger regions of this transcription factor, but really everywhere else in the gene, including deletions, portions of the gene and whole gene deletions, which are important to keep in mind, as well as intronic enhancer deletions that reduce the expression of the gene. This is one of the most common causes of adolescent or pre-adolescent MDS and AML. As you can see here, almost all types of variants can cause AML or MDS that have been associated with it. But the spectrum of disease has really spanned from anywhere, from lymphoid cancers to JMML, MDS, and AML. So it's not restricted to a particular type per se. And one aspect of the immunodeficiency related to GATA2 is that it actually often presents with monocytopenia, as we saw in our first case, and B and NK lymphopenia. So the importance of understanding some of the immune patterns in these diseases is also critical. There's high incidence of atypical mycobacterial infections and warts that sometimes can be that clue you in to think about the MDS or AML differently. And some other manifestations include pulmonary alveolar proteinosis that is thought to be related to macrophage dysfunction in this disorder, and some non-hematopoietic features such as lymphedema, hydrocele, thrombosis, and others. And I have the link here to a fact sheet that is really useful, put together by the NIH for your review. The case two is that of a 21-year-old young man who has leukemia, and there's concern for relapse. And the history of this gentleman is that he actually was diagnosed with BALL at the age of 15, with a BALL that is, it's called PH-like. The actual diagnosis here is not important. The genetic analysis actually showed these findings that are pretty typical for PH-like BALL. There's a rearrangement in a gene called CRLF2. There's a small variant in EZH2, JAK2 variant, and IKCF1 variant at 87%, and a copy a loss of 7p that includes IKCF1 as well. There's a couple of deep deletions that is found on SNP array with 9p and 13q. And again, because neither the pattern or the actual diagnosis at this age of BALL is not unusual, he proceeds with receiving the appropriate therapy as per Children's Oncology Group protocol. Again, not important for the discussion of this case. Now, unfortunately, 3 years after the end of ALL therapy, he presents to the emergency department with shortness of breath and is very quickly found to have pancytopenia, so low blood counts in all lineages, and is diagnosed with leukemia with concern of relapse. And the genetic studies of this leukemia, the second leukemia in him, shows the same IKCF1 variant that was seen in the first time in his first ALL at 51% variant allele frequency, a PAX5 variant that is new, IL-7 receptor variant that is also new, and the same deletion of 9p and 13q at 50% by FISH. And again, given the IKCF1 variant recurrence and the pattern of different genetics in this particular disease, the concern comes up for a germline IKCF1 condition or a deficiency, and a buccal swab is sent that confirms that the IKCF1 variant is actually germline and is responsible probably for the second cancer. So the key points here that I want to pay attention to and discuss briefly is the interpretation and explanation of the clone size. So if we see a variant, for example, IKCF1, that is one of these overlap genes between both somatic leukemogenesis, but also germline leukemogenesis, it's important to understand how this number came to be, right? So, the 87% clone size is probably a combination of having an already first hit, so the heterozygous IKCF1 variant, and an additional copy loss of the wild type IKCF1 on the other chromosome. And so kind of digging into the actual numbers of the VAFs of the variant sizes of the clones could give a clue, at least kind of have a sense that perhaps it does not make sense if this was a somatic mutation only. And of course, the second important point of this case is this different genetic somatic pattern of the second malignancy, even though it has some sense or some findings that are shared between the two. It's just the suspicion of this being related to germline condition is what I'm trying to perhaps underlie here. Is not that it has to be given. This may have been a relapse cancer with just a different type of genetics, but the suspicion for this being germline comes from this different pattern. So 2 words on the IKCF1 gene and other lymphoid leukemia genes. These are overall rare, as far as we know and understand today. There are 2 groups of categories of genetic polymorphisms that have been described. One of them is a common polymorphism that are in a lot of the genes that has been described to date, at a very active research front, and it's incredibly exciting, which aims to understand the multigenic contribution of various genetic variants to high risk leukemia development. And we're not going to talk about these today. But the second group is actually the rare variants in very similar genes, actually, a lot of them the same genes that have a high penetrance susceptibility. And these are the four listed here, and they all have an important role in the development of B cells from HSCs through lymphoid progenitors to pre-pro B cells and pre-B cells, as depicted in this graph. So IKZF1, perhaps underlying up to 1% of BALL, we talked about in this particular case, sometimes also has immunological phenotypes. So there's immune deficiencies associated with this genotypes, and there might be neutropenia depending on the variant. This is a very confusing, actually very interesting gene in itself, and very often also occurs with the somatic IKZF1 deletion. So again, skewing that clone size that can be a clue. A very similar pattern is seen in PAX5, which is much rarer than Icarus deficiency, and it can also co-occur with somatic PAX5 deletion, which is in 9p, and sometimes the actual report or the fish might not say PAX5 deletion, but it notes 9p. So it's kind of important to make that connection between the gene and the loss of chromosome. ETV6 and RUNX1, both of them are related to thrombocytopenia and actually myeloid malignancy risk. But again, both of them have been described in BALL and RUNX1 also in TALL. And interestingly, ETV6 is associated with more hyper-diploid BALL. And RUNX1 is, as I said, is more commonly seen as underlying TALL in a large study that is quoted in this review. I don't have the specific study name on the slide, but you will find it in this review. And the TALLs in this particular case actually very interestingly have a quite unique somatic JAK3 variants that might be important in this pathogenesis and often present as ETP, so early thymic progenitor phenotypes, and that can also be a clue in terms of the uniqueness of the combination. We'll go to case 3 with this, which is that of a 12-year-old boy that has easy bruising with activity. He's a soccer player. Not a big deal, soccer player, bruising, not really unusual, right, in that sense. But the mother is very concerned about this. And the reason is because she herself, not being a soccer player, has easy bruising. She had it in childhood. Maybe it's a little bit better now that she's an adult, but she certainly remembers that being part of her childhood. And furthermore, her own mother, so the grandmother of this child, who was recently diagnosed with myelodysplastic syndrome and underwent stem cell transplantation, also had noted to her physician that she remembers having easy bruising when she was a child. And again, this was very much, very promptly picked up by the physician, the adult provider of the grandmother. And there was a concern for RUNX1 deficiency because of this thrombocytopenia, easy bruising, and MDS susceptibility. There is a somatic cancer panel that is sent with this concern, and it comes back negative. But the provider, being still quite astute and concerned that this might be certainly related to RUNX1, actually sends the buccal swab from the grandmother to a germline panel testing. And this particular testing indeed identifies a heterozygous RUNX1 exon 1-2 deletion, which certainly would not have been picked up by the somatic panel. And one of the key aspects to this particular case to mention is this fact that negative somatic panel testing does not rule out germline conditions, because many of these do not include copy number assessment and will miss deletions, large deletions, or duplications in the gene that are certainly important aspect to the pathogenesis and the diagnosis of the condition. Now, this child at 12 years of age, he's well, again, other than the easy bruising, I think his platelet counts were actually pretty normal even, is having a marrow evaluation because this recommended this time to get a baseline, at least marrow without any concern of disease. And this is what you get in the report, that there's actually dysmegakaryopoiesis, so dysplasia of megakaryocytes with this separated nuclei, abnormal looking megakaryocytes. This is not his marrow. I took this from Dr. Calvo's review that is referenced here, but this would be a quite typical finding, for example, in this particular disorder. I just told you a couple of slides ago that dysplasia is one that you want to be concerned about. However, dysplasia may be normal in some of these conditions, in some germline conditions. So understanding baseline appearance or morphology in these conditions, through family history in a child that is perhaps healthy at this point, is quite critical, because the change in that dysplasia is what actually prompts us to think about disease transformation instead of the actual just absolute presence of this dysplasia in it. So towards a RUNX1 familial disorder, it is an autosomal dominant inherited disease that is one of these inherited thrombocytopenia syndromes that is associated with increased lifetime risk of hematologic malignancies, as Katrine mentioned a few minutes ago. So the group of these disorders that we think about include these 5 genes, anchoring D26, ATP6 that I mentioned before already, MECOM that usually has an early onset, RUNX1, and most recently described ERG. And one of the important findings, maybe most recently from the natural history study of RUNX1 FPD, was this bimodal distribution of neoplasms, first being in the, sort of the first wave being in the first decade of life, and the second being later in life in the fifth, sixth decade, which is a more typical sort of adult onset MDS and AML timeline. Now, the really interesting finding that I thought from this study was that in children, despite the fact that they're coming or stemming from the same germline risk, the myeloid cancers a lot of times had a chromosomal abnormality, which is more typical for children or sort of early onset blood diseases, versus single nucleotide variants that is more typical in adults and certainly seen also in RUNX1 FPD. So even though the germline condition is the same, the somatic pathology or the pathogenesis is quite divergent and more true to the age of the patient. So neither should make you kind of disprove the presence of a germline condition, because that can have differences in presentation. And with incomplete penetrance and really the high suspicion is what leads us to think about some of these older adult onset MDS AMLs and think about our own patients in pediatrics and how to put together those two, and really consider the presence of these cancers in all 3 generations of the family to raise our suspicion. And a couple of other disorders that I just mentioned here, but certainly this is not limited, that typically adult onset diseases might be also in telomere biology diseases in DDX41. And so that again should clue us in despite their older age onset. And the case 4 is a very peculiar one. This is our last case that we'll discuss, and that's of an 11-year-old girl who presents with a really long and quite kind of a discomforting history of lower extremity pain with negative musculoskeletal workup. She has had no personal or family history of any type of health issues, including solid or liquid cancers. And her labs are not very impressive. She has mild anemia for her age, maybe related to the high inflammation. Again, nothing spectacular, but the bone marrow evaluation is eventually done because of this abnormal looking osseous lesions that is seen on imaging, and very curiously and perhaps unexpectedly, she's diagnosed with B-ALL. Now, one of the, as we mentioned, diagnostic evaluation tests that is done in this case is the single nucleotide polymorphism array, or the SNP array, that shows low hypodiploid state. And the somatic panel notes a TP53 variant of unknown significance. And because at that time, low hypodiploid state and TP53 were a combination that would prompt thinking about germline TP53, and we'll talk about that in a moment. There's a cultured skin fibroblast, so the gold standard test is performed for germline, for understanding the germline nature of this variant, and that test comes back negative. Now, one important aspect to this, and I'm sure we can come back to this later on, is that this very variant, that is, sort of variant of unknown significance, not in germline, put to rest, was actually reclassified within a year of her diagnosis to being likely pathogenic. So this dynamic nature of our world is certainly one that we have to keep in mind. So 16 months after her completion of ALL, she presents with pancytopenia and is diagnosed with monosomy 7 MDS with 5% blasts. And interestingly, the somatic panel that is done on the MDS now, there's no BALL in her marrow anymore, shows the same TP3 variant that is detected at a variant allele frequency of 45%. And indeed, when she has, MDS-directed cytoreductive therapy, after which very, very small, if any, sign of MDS is left in the marrow, this particular variant is still at about heterozygous variant allele frequency at 49. So what is this variant? Is this germline or not, is the question. So, as promised, a couple of words on haplodiploid ALL and TP53. It is altered in over 90% of pediatric low hypodiploid ALL, and these are ALLs that have chromosomal numbers of 31 to 39, but they also might present as something called masked hypodiploid and appear to be hyperdiploid. Not important again for this discussion, but something to keep in mind. And it's very rare to find in other BALLs. And so in addition to it being quite common as a somatic genetic alteration, almost 50% or 43% of these patients also had this the variant in non-tumor cells, suggesting of a high association with germline TP53, which is and low haplodiploid ALL really represents a manifestation and may be the first manifestation of Li-Fraumeni syndrome. Now, Li-Fraumeni syndrome, as many of us know, is germline TP53 state with heterozygous mutations. And what this means really is that it's affecting all the tissues in the body. It's probably in the zygote, whether it's inherited or not, but it's really present in all tissues. And this is where the risk of cancer comes in every tissue of the body, and particularly pertaining to leukemia, the additional mutations lead to the cancer, typically with actually loss of the other TP53, for example, to leukemia. Now, another state that has been described in TP53 variants and also other mutations typically found in solid tumor cancer is this concept of post-zygotic mosaicism, where the TP53 variants may be found in some cells, but not all cells in the body. And what an unusual situation might be that the actual blood tissue, the hematopoietic tissue that is coming from mesoderm, for example, might be the only one that has the TP53 variant and acquires the additional mutations to go to leukemia. But for example, the buccal cells that you test or the skin fibroblasts that are very related in germline origin to blood tissues might be negative for this mutation. And this is in contrast to, for example, a somatic acquisition of TP53, which is basically coming from a wild type of blood cell and then acquires the mutation later. And indeed, what this case was that of a post-zygotic mosaicism for TP53. And from the perspective of hematological cancers, these patients really behave like LFS in the blood, right? So Li-Fraumeni syndrome, but only retaining to the blood tissue. And in fact, the recommendation for patients who have post-zygotic mosaicism is to follow them like patients with LFS, because we do not know what is the extent of mosaicism, and we can't really sample every tissue to find that out. And so they're followed as such. And one question that I want to pose maybe for our discussion later is, in addition to germline non-hematological tissue testing, which is pretty standard, as I mentioned, in our world, should every patient with low hypodiploid ALL who has a TP53 variant have a remission marrow sequencing to kind of appreciate or document the presence or absence of post-zygotic mosaicism? So to conclude, I want to give you, again, just to summarize the clues that we use to recognize hereditary pediatric hematologic malignancies. And one of them is the pathological findings in the marrow. So the dysplasia, an AML that has dysplastic features, and hypoplastic, for example, hypocellular marrow that has dysplasia. Although again, the exception for the rules, right? So not all dysplasia is disease. So recognizing that sometimes this might be part of the normal disorder is important. Multiple hematological or non-hematologic malignancy should definitely be a clue, whether it's a different type of cancer or has different genetics. And this is by no means to say that these are clues to like 100% diagnoses of hereditary conditions, of course, but these are things that you can increase your suspicion for it and test to be sure it's not the case. I mentioned the overlap genes, heterozygous or close to heterozygous clone size. And these are some of the genes that we could come up with, but certainly the list is not exhaustive. And so, thinking about some of these genes, when you see the somatic panel, be sure to explain and account for the clone size and make sure that it kind of matches what you would expect with the presence or relative to the presence of the blasts in the marrow. And lastly, the somatic landscape of genetic alterations, or how the cancer kind of evolved, or at least at what state we find it in, can be a clue. So an AML that has multiple STAC2 mutations is not really typical and should clue us in that there might be an underlying genetic condition that actually made this patient or resulted in this patient having multiple STAC2 mutations. Or, for example, a splice factor variant in a young patient with MDS quite unusual in pediatrics, and again, should prompt us to think about something that is underlying. And one amazing wheel of mutations or genetic alterations that I've adopted from Marcin Ledarski, who's at St. Jude, and I've been updating this over time for the past few years, is this idea that every somatic, every germline condition has a little bit of a favorite landscape of somatic mutations, and sort of we could use that echo, that landscape to actually understand or perhaps have our suspicion for underlying germline condition. And this is by no means exhaustive, and I want to make sure to highlight this other and variable piece of the pie that is the most dynamic probably in our world, and things change every day. And so this chart can be updated almost on an annual basis, and we'll have new things that are added to it. And then the tools to work up our suspected cases are really the comprehensive personal and family history that includes hematological and non-hematological presentations, comprehensive workup with labs, I mentioned, including immunological assessment of lymphocyte subsets and immunoglobulin levels, for example. The bone marrow evaluation should be comprehensive. That includes not only the typical karyotype and FISH assessment, but also SNP array and a somatic panel that could prompt us to think about some of these findings. Appropriate use of germline testing and sort of using the correct panels and that involve the genes perhaps that we're suspicious for is important. And I already mentioned that negative somatic panel does not rule out germline condition. And lastly, I do want to stress again this idea of revisiting old testing panels. So if somebody has had a negative workup 10 years ago, might not be quite negative today because that germline panels are different, and the variants of unknown significance do get reclassified. So I definitely keep track of all the VUSs that I have in my patient cohort, and continuously from time to time just check up on these new variants or reclassification just to see if that has changed over time. So that is all for me. I want to thank you for your attention. I just want to maybe leave you with the additional references here that I didn't have a chance to specifically address, or reviews that I find useful for you to look at later. Thank you.
Oh, that's great, Serene. Maybe we can leave your slide up for a little bit in case people want to take the notes. Thank you so much for your presentation. I thought the cases were really helpful in understanding the signals one can look out for in order to suspect an underlying germline variant. I'm looking forward to the discussion. So please enter your questions. We already have 4, and Dr. Pollard, Sara, please join us for our Q&A. I'm delighted to have you both here with us, and I'll introduce you now formally. So Dr. Jess Pollard is an assistant professor, and she is clinical director of the Hematologic Malignancies program, associate professor at Harvard Medical School, a senior physician at Dana-Farber Boston Children's Cancer and Blood Disorders Center. And then we also have with us Sara Torres-Esquius, who is a genetic counselor in the Hematological Genetic Diagnosis and Counseling Unit at Vall d'Hebron. I don't know if I said that right. University Hospital in Barcelona. Welcome to you both. All right, so I'm going to just jump into some of the questions, and I will start with, I kind of want to start one with, let's see, we have quite a few. We'll start with an easy one. So there was a case, and I'd like for each of you to comment on this. There was a case where a buccal swab was used as a DNA source instead of fibroblasts, and maybe each of you can comment on when it might be appropriate, when there's a scenario it's appropriate to use a buccal swab versus trying to get skin fibroblasts. How about we start with you, Dr. Pollard?
Sure. So we definitely try to stick with the gold standard of using skin fibroblasts. However, we recognize there are scenarios that may be less suggestive of a germline disorder. For example, in children with ALL, Serene had that nice image that shows that the rates are relatively low. So what we have opted to do for ALL patients who we don't have clinical suspicion, but the family would like testing, we will consider buccal testing should the patient be demonstrated to be in remission from their ALL. So it's not a perfect assay, and it does speak to if a positive finding is found, we do like to ideally confirm by cultured skin fibroblasts. But we do take that approach in some instances. The other scenario, obviously, is if we're really pressed for time. And if there's some reason why we can't do a skin biopsy in a timely fashion, perhaps the patient is in the region and we want to sort of explore considerations of germline for donor considerations, et cetera. So, we may send out a buccal swab to the family for them to do the swabs, understanding that, again, if the test is positive, that it really should be validated with fibroblasts as well.
Great, thank you. Is there anything that you, Sarah, or Serene would want to, Dr. Avagyan, want to contribute or add to that?
Well, I agree 100%. And the ideal is to have the skin fibroblasts, but sometimes we need to speed. We need to be quicker than the 3 weeks time that it takes with this culture skin fibroblasts. So what we are using hair follicle, and it works pretty well, especially if they haven't started the treatment yet. So if the patient is untreated, it's pretty easy to get, and it's really quick. And we are using only buccal swabs when the patient is in treatment or it has no hair. If we cannot use skin fibroblasts because we are waiting for a transplantation or something like that. Obviously, the ideal is one thing, but the real is another thing.
Absolutely. I'm curious, actually, on average, how often do you end up being able to use skin fibroblasts in these settings? Is it 50%? Is it 20%? Is it 80%?
I'd say it's probably 90 or higher.
Oh, okay.
It's just a question of if for some reason they don't grow, but that's, I mean, depending on who your vendor is or where you do your culturing, that can vary, but usually it's very effective.
Yeah. As a stem cell transplant person who probably is at the end of that conversation a lot of times, right? Like the referral of like, oh, we think there's something that needs to be fixed with stem cell transplant. They're in their second cycle of chemotherapy. You have no time, right? We basically have 4 weeks to decide who is the donor and work up. So skin fibroblasts at that point become quite lengthy in time. So you sort of want to have the most information you can. So I think the buccal swabs for that reason, or for example, hair follicles would be the easiest. So in terms of efficiency, I agree with Dr. Pollard. It's very efficient to get fibroblast testing. It's just that the actual process takes up to, I mean, at least 3 or 4 weeks to grow, and then another, right, like a few weeks to get the genetic testing done. So it's a long time.
Are there scenarios where if you don't have the gold standard, but you have a buccal swab that comes back positive, you just go, you obviously just assume that this is germline and you move forward as such. Yeah, there's never a reason you would be concerned. Okay.
Yeah, and actually just to kind of come back to the case one, for example, if let's say we just tested the blood of the mother, right? So I mentioned that very small variant size of the mother, but it's the same variant. And that itself would make the variant in the child be obligatory germline, right? Like the probability of this being an independent event is so low that even if we didn't have, let's say for some reason the buccal swabs fails or whatever, and you only have this very small information in the blood, that would have been enough.
That's enough. Perfect.
I actually have one question regarding case one. I don't know if I can jump in.
Yes, please, please.
Yeah, okay. So the mother in this case is a really nice example because it already has the somatic rescue. And in practice, we sometimes, at least in our practice, we sometimes use peripheral blood for cascade testing if it's like 100% healthy or normal blood counts or whatever. So I don't know, given how often we can see somatic gene rescue in data2 and 79, are we at a point where we should consider like hair follicle or cultural skill fibroblasts for all relatives? I don't know, what are you doing in the daily basis?
Yeah, I mean, the blood test was really sort of the quickest way while the buccal swab was pending. As I said, with low level blasts, right? Like there's a lot of also times no cytoreductive therapy going to transplant. So you really are, against time. You just want that information. And this case was when I was in Dana-Farber, and there's a panel there that results within 7 days, right? 5 business days. Like that information is so quick. You can get that so fast that it sort of gives you planning ability But if this variant was rescued to a point where the blood was less than 2% and the panel is not calling mutations at less than whatever VAF that it's calling, you would miss it. So I think it's still exceptionally important to do non-blood tissue.
Yeah, I think it's a really good point too.
All right.
Sorry, in our practice, we are just to say that we are using non-blood tissue only in those variant who has been described somatic gene rescue, because we cannot do punch to everyone.
To be honest, at the time when we found this case, I had only a single case of GATA2 somatic gene rescue in literature. I don't think it has been described that much. So it actually was a very unique, personally for me at that time, I was like, oh, wow, this is like the second case I know in the whole entire world. Because not everybody publishes it, right? They might know about it, but it's not in the literature.
Right. All right, so we have a question here. I'm going to read it out loud here. For those that you follow as full Li-Fraumeni syndrome whose TP53 somatic variant is not identified in the skin or buccal, do you automatically follow as a Li-Fraumeni syndrome if negative for germline testing? Are there any cases in which somatic TP53 variant is identified in the blood and germline testing is normal that you do not follow as full Li-Fraumeni syndrome?
These are rare cases, as you might imagine, and I mean, we've had two in the past few years that have been at UCSF, and delving into the literature in the context of this particular patient, I just really recognize that it's a very, it's an uncharted territory, and like between low level post-mosaicism, which is actually more common in adults, which is 99% of literature comes from, to something that is basically heterozygous, right? Which is really rare. So the maximum VAFs in mosaic cases that have been described is like 20, 30%, right? Not 50%, 100% heterozygous. And the reason that was actually low at the beginning was because she had a 17p deletion, and so the VAF was unusually lower because of that biallelic loss. It actually went up after the therapy. So at this point, the recommendation is presume that there might be mosaicism in other tissues. That's basically the bottom line. I don't know, the course that this particular patient experienced might suggest that there was toxicity in tissues that we would not expect, but sometimes the toxicity of transplant is such that it's just unpredictable to put in the like more toxic or less toxic. But I would say there were some unusual features that I would think that perhaps were related to mosaicism in other tissues. So the recommendation right now is to follow as if they have LFS.
Great, thank you.
Including family testing,
right.
Pregnancy-related genetic, prenatal genetic testing, etc. By the way, because it could be also in germline cells, in germ cells.
Maybe I'll just jump on the idea of family testing, cascade testing, and then we can come back to there's more questions. But you mentioned, and understandably, of course, when you're dealing with a pediatric patient with malignancy, the focus is really about that individual and his or her treatment. And so you're not necessarily doing a complete cascade testing of the entire family at that time. When is the right time? When do you bring this back up? Because I'm sure if the outcomes were not positive, it's not a great time. And if the outcomes are positive, they probably want to move on and not even think about this. So what do you all suggest is the right time to bring up this discussion on cascade testing?
And I'll take this one because it does come up a lot. I think the honest truth is it's family dependent, scenario dependent. We've had patients, families who have, once they hear that the patient has been affected, they want everyone tested, et cetera. There's others that just are like, we are overwhelmed and this is not what we want to do right now. And we definitely try to support that, while also keeping them on our radar, because what we don't want to do is, have them go back to their referring institution or wherever and this never be followed up. And so we just do try to there's a core group of us that kind of keep track of these families, and then do, let's say the patient gets through transplant, things are going better. We then do sit down with them and say, hey, you may remember we talked about how we should test the family, or sometimes they've got the test results, but they don't really want to deal with them. And so then we'll say, you know what, it might be a good time to at least just see the sibling and just check some labs and sort of start the process. So it is a sensitive time, but I definitely think it is important to keep track of those families for those reasons.
Thank you. Absolutely. Anything to add, Sarah?
Yeah, no, pretty much the same here. We keep track of them, and usually the response is pretty great. I mean, they are open to share their genetic testing results with the family, and yeah, we wait a little bit, of course, if the outcome is not great. But additionally, they want to avoid maybe or to let their relatives know that something is happening and maybe to be able to prevent that. So we have a really positive outcome, keeping track within a month or a couple of months.
That's great.
Yeah, I think one very interesting aspect, I think, to this is something called the obligatory state, right? So if you, for example, find a grandmother and a grandchild with the same germline mutation, that makes the generation in between an obligatory
Right.
person who's affected. So there's this, and definitely there are people who are like, I'm not going to be tested, but you know that they must, like, that's just by definition. Same thing, for example, with two siblings who are related and have the same parents and have the same variant. That makes one of the parents either an obligatory affected individual, or at least they have in germline. And so for purposes of some of these sort of nuanced discussions, is also important sort of to understand, like, we have to watch this person because we know that they might have obligatory carrier state. I don't want to use that word, but
Right.
a state that
Yeah.
is affected. And particularly in dominant diseases and dominant inheritance diseases, it becomes a very big issue that there might be family members who are affected, where we have, for example, a family of like 7 members, and they all have different presentations of the particular disease. And we found one of the cousins sort of related to this because of this discussion that you
Wow.
have to, let not to have to, but we would really strongly recommend to share this with the family member. Yeah.
That's great.
Yeah.
This is in line with the next question that was asked was, how often are these variants de novo? And does it depend on the type of syndrome or disease?
Yeah, it's so in GATA2, I mean, one of the most, probably the literature that I know best is about 2 to 1. So two being being de novo more common than
Oh,
inherited.
wow.
So yeah, in even in dominant states, you might actually find more de novo now. But I don't know if, because we don't do as much testing, right, to know some of these
Of actual.
disorders as the actual numbers. But
Yeah.
it's very possible. There's no sort of rule that says it
That
has to
brings
be
to my
inherited.
mind a case we just had. It was a Varix1 variant, and it was de novo, but we didn't perform a paternity test. And that's a question that, should we? Because nothing, I mean, if the variant is pathogenic or likely pathogenic, nothing will change. So we are not performing a paternity test if the variant seems to be de novo, unless it can change the variant classification. But yeah, it's not that frequent. We only have like a couple of patients, I think, with the de novo variant.
Yeah, and I would say we also don't, for those rare cases, we also don't do paternity, although some of them are, getting HLA typing for transplant, so you can figure it out from that. But agreed, that's not our standard to say, oh, we'll do paternity just to make sure.
Same. Mhm.
Okay, thank you. Serene, in your presentation, you had a couple of cases where the variants, well, in the GATA2 case, you talked about the fact that there are intronic variants and there are variants in enhancer regions. And then in the RUNX1 case, you gave an example of a deletion. To me, the takeaway is you have to be a really astute clinician to catch these and say, well, no, I still have suspicion. I still need to get another test because am I wrong? Is it true that a lot of the somatic panel tests aren't going to be capturing intronic variants or deletions if you don't get, copy number variant tests? So how do you help the audience become that sort of astute clinician that says, I'm not going to stop here? How do you know when to stop?
I mean, I think unless, so, if the suspicion is there, again, the pattern, the dysplasia, etc., I feel like I don't want to put the ball down until I know the answer, right? That's the way to think about. And the way that I approach that, for example, at UCSF, the panel, the somatic panel, something called UC 500, it actually does have some SNP array components and hotspots of cancer. For example, 7Q is covered, 17P is covered, 7P is covered, right? Like some of the hotspots are covered. So knowing that, so coming here, for example, was my first thing is like, what do I have in my coverage that will make me comfortable or not? But at the end of the day, if the variant is not on the actual panel, like, let's say a dysplastic AML with monosomy 7, GATA2 is top of my mind in a 17-year-old. If I see a GATA2 variant on the somatic panel, meaning the panel captures the variant that is most suspicious for, there's no, you could use that panel even for germline
Yeah,
testing.
that's enough. Yeah.
Right, that's enough. It's when you don't see that, but your suspicion is still quite high that we're missing something to explain the actual presentation is when you go, like in the case of Rank Swan, right? So I feel like it's the high suspicion that drives this, but also recognition of what is covered or not with the means that one has. And some of these, for example, foundation medicine, some of the commercial, I don't want to like specifically name things, but some of the commercial available panels also have a germline component to them, or they can actually kind of get dilutions and duplications. So knowing that should make you feel more comfortable. But read the fine line. Is there del-dup calling in this particular panel or not? And it unfortunately it is kind of, I don't mean to say it's like, oh, it takes like the scientific thinking to learn this, but it is an important piece to understand sort of what is actually given in the report and what is missing from the report.
Yeah.
Yeah, just to add, I mean, I think that the intronic GATA2 is a perfect example because a lot of somatic panels obviously don't include that. And I think that if you aren't well versed in this world, you don't realize that. And so I think Serine's point of if your gut says that something's off, trust your gut. And maybe you reach out. So there, for example, NAPAC has a tumor board where you can present complex
Oh,
patients.
that's a great idea.
There's another tumor board that Lucy Godley runs. So reach out to those providers, or certainly anyone's welcome to reach out to me, but recognize that you might need to phone a friend, because if you're not savvy in molecular, and I'm certainly not nearly as savvy as Serine is, you do have to rely on people who really understand it. We are incredibly blessed here to have amazing cancer genetic counselors who frankly have better understanding of the diagnostics than probably half the physicians. But if you're not at a center with that, I will say that I do think that thankfully, at least in pediatrics, it's a very collaborative world and people are happy to help. And so, reach out to a bigger center if your gut says something's off, but you don't think that you have an understanding of what you're missing.
I thank you so much for that point, and I'm embarrassed that we didn't even highlight that. We've done that in previous webinars, that there are these tumor boards.
Yeah.
And we have a genetic counseling working group that is very active. I mean, I think at least twice a week we see cases being brought up where people are trying to help each other. So we'll send to all the registrants of this webinar that information. I think that's a really good idea. Yeah, like I said, I'm embarrassed we didn't put that on the slide earlier. So good point,
I should too.
Dr. Pollard. Yeah.
Thanks, Jess.
I think we should close up. There are a few more questions. If there's anything we didn't get to address, we will maybe perhaps send the three of you panelists the questions and see if we can quickly answer them offline, and then send it out to all the registrants. So with that, I can't thank all of you enough for being here. And Serine, thank you so much for the presentation. It was really well done. And have a great day, everyone. Thanks for being here.